Good morning, everyone, and thank you very much for coming in. This is season 3 of the cardiology master classes, and today is part 2 of the ECG. So we're just going to very quickly recap of what we said last time. We started with assumptions, didn't we? So the assumptions from this series is that, these are based for non-cardiologists. We're starting from the very basics, and then we're advancing, so it might look boring initially, but eventually it gets more complex, and the idea is to give you practical tips and tricks of how to deal with various cardiology issues. We'll be tackling various cardiology topics, so ECGs, aortic stenosis, atrial fibrillation, chest pains, mitral rigor. So the common presentation which I think you'll be encountering more frequently on A&E or on the wards or in your kind of daily practice as a clinician. Last time we talked about the basics of the ECG, how to look at the complex and identify the names of the complex Q waves, R waves, QRS, T waves, and so on. We discussed about the rhythm, how to identify sinus rhythm, how to identify whether it's regular or not. We identified how to address the rate, how to decide if, what's the rate for regular and irregular rhythms as well. And we touched as well on bundle branch blocks and why bundle branch blocks look the way they are. I've had a few emails after the last talk, thinking about the bundle branch block. So again, if we have time today, we'll go through them. But let's crack on. So we're going to start with talking about bradycardias and heart blocks. And what's the definition for bradycardia? Very good. Okay. So whenever you see a heart rate less than 60, you need to start saying, okay, there's a bradycardia in this ECG. And we know that basically, where does the electrical impulse start in the heart? Synovial node. And this activates the atria and results in a P wave. Yeah? Okay, happy? And then what happens? After the sinus node activation, atria is activated, goes to the AV node. Yeah? And then you get activation of the ventricles, yeah? And what does activation of the ventricles give you on the ECG? Very good. Okay. So you get a QRS. And basically, as we mentioned, what you need is you need the heart to be coordinated. So you need the atria to contract before the ventricles, right? So you need the atria to activate, contract, empty the blood, and then you need the ventricles to fill up, yeah, and then contract. And what you can then have is the delay across the AV node, and this is what gives you basically this timing of bradycardia. So this is what gives you the timing to allow the atria to contract, delay at the border control here at the AV node, and then you get the ventricle activation. And this delay here, this border control, gives you the PR interval. Okay? So when we're talking about bradycardia, you can have issues with the sinus node, issues with the AV node, or issues with the bundles as we mentioned previously. All right, so these are the three sources that would give you bradycardia basically on an ECG. Right, so let's get on with this ECG. So the first question, just like last time, is ask yourself, is this a regular ECG? Yeah, it's regular. So if it's regular, the next question I would ask myself, is it sinus or not? Because most of regular ECGs that you'll be encountering is going to be sinus. Common things are common, so this is going to be sinus rhythm. So how do you know if it's sinus or not? Alright, so you look for the pattern, which is one P wave followed by one QRS preceded by one P wave, right? So PQRS, 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 and you can see here PQRS, 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 and so on, right? So it's a sinus rhythm. And then what's the rate? You say that this is, 6 squares. So how do you calculate rates in regular rhythms? 300 divided by 6 is going to give you 50. This is bradycardia basically. Yeah. So what type of bradycardia is it then? So remember, it could either be sinus, could either be in the node, or it could be in the bundles. Yeah. So it's a sinus bradycardia. So the rate is less than 60, and it is a sinus bradycardia. So this is the problem. And what is causing this? So what's the cause for this bradycardia? Yeah, so it could be just degenerative, something is, someone is just getting old and the sinus node is getting ill. It could be that the sinus node is very well trained in athletes and it's just have got a low resting kind of output. What else could cause sinus bradycardia? So drugs could cause that. What? Hypothyroidism. Okay, so certain conditions as well. Very good. Hypothermia. Excellent. Right. Is this regular? Yeah. And what's the rhythm? So if we said it's regular, so what's the rhythm? Very good, yeah. Sinus, because I can see one pure QRS, one pure QRS, one pure QRS. And what's the rate here? So if you know that this is like 5 or 4.5 squares, 5 squares, let's say. 60, yeah. So it's not bradycardia, yeah. So it's 60, 62 maybe. It's not bradycardia. But when you look at an ECG and you're looking at the P wave, are you noticing anything, between the P wave and the QRS? Prolonged PR, alright? So this basically means that when you start seeing an ECG, just try and incorporate this question into your mind quickly. So I'm going to ask about, is it regular or not? What's the rhythm here? I'm going to ask about the rate, and then just like we're doing with the ECGs, with the QRS last time, I'm asking, is there a bundle or not? Just ask yourself, if it's grossly abnormal, just keep an eye on this, right? Because this is abnormal, it should be just one big square, right? So 0.2 seconds. If you start having more than one big square, so almost 2 big squares between the beginning of the P wave and the beginning of the QRS, then this means that this is a prolonged PR interval. All right? And this is basically first degree heart block. All right? And this means that to have a first degree heart block, you don't have to have a bradycardia. Okay, so you can have them both separate. So it doesn't always have to be bradycardia to trigger you asking, is there a problem here or not? And this is important because obviously the problem here is going to be in the AV node, yeah? And if you start giving more medications for this, to rate controlling medications, then you're going to prolong the PR interval, prolong, and eventually you're going to completely cut the communication between the top and bottom. Okay? So when you're looking at an ECG, you're going to ask, is it regular or not? What is the rhythm? Right? And we're going to just go through these questions in our minds and keep an eye on the PR interval. All right? Good. Is this regular? Yeah? What's the rhythm here? So keep it simple. So whenever so what I want you to learn basically from these sessions is that when you look at an ECG, take a deep breath in. All right? So if anyone gives you an ECG, just take a breath, all right? Remember the pigeons we talked about last time, all right? And then you look at an ECG and you say, fine, what's the question here? So all I'm asking you is, what is it regular or not? You answer that, yeah. What's the rhythm? Science. Yeah, science, okay. Why? Because there's PQRS, yeah? We're just keeping it very simple here, right? And what's the rate? There's like 4 squares. 75, excellent, yeah. So you already answered like 50% of the ECG, rate, rhythm, and regular or not. Okay. So now just incorporate this question that we mentioned, a few minutes ago. So what's the PR doing here? And again, as we mentioned, you've got 12 leads to look at. So if you can't see a P wave in one of them, you can't see P wave here. Look at one where you can see a P wave. So PQRS. Then I can't see it here. I can see it here. So that's PQRS, yeah? What's happening with this PR interval?
Prolonged.
Very prolonged, yeah. So this is, so PR interval is more than one big square. It's first degree heart block, okay? So just keep it simple, right? So there might be other things in the ECG, but we're just taking it chunking it away. So we're just taking one step at a time so that you turn a big, massive task into a smaller little chunks and you can get the job done, okay? And obviously now you can then start asking, okay, well, what's the elephant in this ECG? What's abnormal here in this ECG?
It's an inferior step.
Yeah. And you all see that there's an ST elevation here in the inferior leads. Yeah. So there's inferior, and this is another reason for having heart blocks, right? Is if you're getting ischemia, acute MI, this can cause you to have, because the right coronary artery basically supplies the AV node, and if you have a blockage in the right coronary artery, the AV node goes down, and so you start having this first degree heart block. If you leave it too much, you get complete heart block. Okay. this regular? Yeah, agreed, well done. What's the rate? So there's like 10 big squares. 30, right? So this is bradycardia. Okay, now you switch on the bradycardia chapter in your mind. Okay, so remember, if you decide it's bradycardia, it could be from the sinus node, could be from the AV node, it could be from the mundane. Yeah? So what do you think is happening here? What's the rhythm, first of all? So we said it's regular. Yeah? We said the rate. We said what's the rhythm? If it's regular, usually it's going to be sinus, yeah. Sinus, very good, yeah. So I can see PQRS, 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 but what's happening here? So there's T-wave inversion, yeah. So keep your focus on the question. So what is happening here with the bradycardia? So the question is bradycardia. Why is this guy bradycardic? Yeah, yeah. So we said it's sinus, but to have sinus, the rule is you have to have one P wave followed by one QRS, and one QRS preceded by one P wave. Right? So the first condition here is met, so one P wave QRS, P wave QRS, P wave QRS, but here if you go QRS preceded by 1, 2 P waves, QRS preceded by 1, 2, 1, 2, okay? So there's 2 P waves for every QRS. Why?
Is it re-entry into the atria of the conduction?
Yeah, so it's not a re-entry. So what's happening here, imagine the atria is contracting, so the atria is doing what it was designed to do. So the sinus node is firing away. Boom, 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 boom. Yeah, so the sinus is doing what it should do. But the ventricle is not getting, there's a miscommunication between both of them, yeah? So the atria is contracting, it's doing what it's woke up in the morning to do, but then what does the QRS are just responding to every second beat? Why? Where's the problem here? AV node, excellent, right? So the AV node is something is wrong with the AV node, whether it's drugs, whether it's ischemia, whether it's hypothyroidism, whether it's hypothermia, right? But the AV node is not passing away all the signals. Okay, it's delaying every second beat, right? It gets tired after one beat, it just says, I'm going to take the rest of the day off. So it switches off for another beat, and so on and so forth, okay? Right, so you can see, so remember for sinus rhythm, it is a sinus rhythm at the end of the day because the sinus is firing away, but it's not a complete sinus because the two conditions are not met, which is one P wave followed by one QRS preceded by one P wave, okay? Good, and this is a 2-to-1 heart clock.
So what's the rhythm?
So it's a sinus rhythm, because the sinus is still firing away, but it's not a complete sinus rhythm. It's called 2-to-1 heart clock. Right? So it would still be called sinus rhythm. Yeah?
Doesn't make sense. Because your criteria are met, so what do your criteria mean?
Yeah, so it's sinus in the sense, it's sinus with 2-to-1 heart clock. So it's fine. Yeah, sorry, my mistake. It's not sinus rhythm. It's sinus with 2-to-1 heart clock. Okay, yeah, you're right. Is that clear? Yeah. So, and remember that in 2-to-1 heart blocks, the P waves are still maintaining the relationship with the QRSs, right? And this will become clearer later. So here, the P wave is followed by QRS, P waves are followed by QRS, P waves are followed by QRS, right? So this is sinus rhythm with 2-to-1 heart block. Okay, good. Right, well, what's happening here? Is this regular?
Yeah.
Excellent, good. What's the rate? There's like 6 squares. 50, okay. And what's the rhythm here? So pick a lead where you can see things clearly.
Sinus.
Excellent, yeah. Sinus. So now you look for, because it's regular, usually it's going to be sinus, right? So if you're betting, you can say sinus and then start looking for clues. And then if it's regular, you said sinus, now let's look for the two conditions. So I'm looking for one P wave followed by one QRS preceded by one P wave. So let's see if these two conditions are met. What do you guys think? Yeah, so there's P wave followed by QRS, P wave followed by QRS, PQRS, PQRS. But let's see the second condition, QRS 1, 2. Yeah? Can you guys see that? P wave, QRS 1, 2. P waves. QRS 1, 2. So what's that? Excellent. So what would you call this? Excellent. Good. And remember again that the P waves, when they occur, they are followed by the QRS. Right? And again, this will become clear shortly. Right? Is this regular? Okay. It's regular. What's the rate here? If we say there's like 8 squares or 6 squares, it's going to be bradycardic basically. So we're asking this is bradycardia. And what's the rhythm here?
Sinus.
Okay. So we said in order to have sinus, you have to have P wave followed by QRS. Yeah? So I can see a P wave here, and maybe a QRS. P wave, and then a bizarre complex, and then QRS. P wave, QRS, P wave, QRS. But the P wave is not keeping a constant relationship with the QRSs. Look at this one here, for example. You get P wave, QRS. So you could say maybe 2 to 1, right? A P, QRS. You get here just one P wave, QRS. Here you get a P wave that's not maintaining the relationship. Remember this sentence we said, the P wave have to maintain the relationship with the QRSs. Yeah? But here, you can, if you look at just this beat on its own, you can say this is PQRS, yeah? You can say this is sinus. But then you can't see it elsewhere. What's happening with the PR interval here? The PR here is, getting in and out. The P wave is not in keeping in sync with the QRSs. So what would this be?
Complete heart block.
Very good. Okay? So if you ever see an ECG where the P waves are not really maintaining this nice relationship, boom, boom, tap, boom, boom, tap, boom, boom, tap, boom, boom, tap, yeah? 2 to 1 heart block, or 3 to 1 heart block, or 4 to 1 heart block, where you see boom, 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 tap, boom, 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 tap, boom, boom, boom. So you're seeing P waves, but you're not seeing this a standard relationship or a rhythm to them in relation to the QRS. Yeah? Good. Is this regular?
Yeah.
Yeah, it's regular. What's the rate if there's like 10 squares? 30, okay. What's the rhythm here? I can't say really, because there's no this, even though it's regular, I can't see a PQRS, I can't see an atrial flutter, I can't see like a regular tachycardia, a regular bradycardia that would cause this. Okay, so I'm in the bradycardia chapter, so it could be the sinus node, but it's not a question of just a delayed P wave and then QRS follows, so it's not sinus. AV nodes, possibly AV node, because I can see here perhaps PQRS, but then I lose completely the relationship. Yeah, so the P wave is here, another P wave is here, another P wave is here, another P wave here, P wave, P wave, P wave. So the P waves are working, so the sinus node is working here. Okay, so the sinus node is firing, but the QRSs, the ventricle, are completely out of sync. The QRS are just doing their own thing. Yeah? Can you guys see that? So what could possibly be happening here? So we said it's not in the sinus node. It's in the communication between the sinus and the ventricle, between the atria and the ventricles, yeah? So it's something in the AV node. And if it's something in the AV node, then it's going to be either first degree heart block. Doesn't look like a first degree heart block here. 2 to 1 heart block. It's not keeping this regular nice boom boom tap pattern. Yeah? So it can only be complete heart block. Okay? Right. And as you can see, again in 2, 3 and AVF, you've got this massive ST elevation here. Right? This massive inferior ST elevation. So it's ischemia. And this is how patients with inferior usually present. So if you're an A&E or if you're working in in a cardiology setting, you get someone coming in with an inferior stem in the ambulance, and they tell you they went into complete heart block, they required atropine, they went bradycardic, they had a cardiac arrest. All right? because of that, because of the AV node issue. Good. If you have got, an extreme heart block, okay, so here what's happening is that, the ventricles were not designed to have pacemakers, but they do chip in every now and again when it's like life-threatening. They've got like these, all the heart has got what we call like pacemaker cells. The most active is in the sinus node, followed by the AV node, followed by an area in the junction, followed by a few places in the ventricles. But the pacemakers in the ventricles are very unreliable, and they're just like a torch, just like in an emergency, they just would buy you some time, bridge you some time until you fix the problem. Okay? So when you have complete heart block, nothing is going through the AV node, you switch on the emergency batteries. Okay? So here these are the ventricles trying to activate, just trying to flip and do whatever, anything to just keep the person going, keep that life going basically. Okay? But if you have an episode where you don't have this emergency supplies, these emergency batteries in the ventricles, you go into this. What's happening here? P waves. Yeah? So these are just P waves. Sinus, not sinus, 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 but no one's picking up on the other end. Alright? There's no emergency supplies. There's no AV node pacemaker. There's no junctional pacemaker. There's no ventricular pacemaker. So what would happen to this patient here? Collapse, yeah, exactly. Right? So if you're seeing someone with a collapse, and usually this is the ambulance ECG that gets just thrown away when the patient goes to the wards, these are very important because if you see this explains why the patient collapsed. Right? And then you can see here that this guy has got serious conduction issues, because then he goes in when he starts, when the node starts picking up again, you start having 2 to 1. Yeah? And then you start having first degree, complete heart block here. You see this P wave is not just marching in and out of the QRSs. Okay. Good. Now let's talk about tachycardias. And to have tachycardia, you have to have a heart rate higher than 100 basically. I think there must have been. Okay, so when we talk about tachyarrhythmias, it could either result from 2 areas basically in the heart. Right? You could either have supraventricular, above the ventricle, or you could have ventricular arrhythmias. Alright, so these are the 2 areas where you can have tachyarrhythmias, supraventricular and ventricular. And when we talk about supraventricular, you could either have sinus tachycardia, you could have atrial fibrillation or flutter, so multiple pacemakers in the top chamber, alright, or you could have what we call reentrant tachycardia, or loop tachycardia. Okay, and we'll go through them. So let's go through them. So what's happening here? What is it regular? Yeah, agree. And if I tell you there's like 3 big squares between each QRS, so what's the rate? 100, very good. What's the rhythm here? Very good, because I can see 1 P wave QRS, 1 P wave QRS, 1 P wave QRS, 1 QRS preceded by 1 P wave, 1 QRS preceded by 1 P wave, and so on. Okay? So this is sinus tachycardia, yeah, so it's sinus, rate of 120, and it's a sinus tachy. And what could cause this?
Sorry, I can ask, why is the T wave not important in whether it's sinus or not?
Why is
The T wave not important whether it's sinus or not?
Because it's the T wave is just a recovery wave, so it's just do you know when people swim fly, for example? When people do fly stroke. So you start the kick there, and then your legs have to follow with the fly stroke. Yeah, so the T wave will come anyway, will be dragged along anyway. So it's not initiating the impulse. It's not controlling. It's just doing, it's just reacting. And this is why in ischemia, for example, the T wave gets flipped, because it's just reacting to the actual problem, which is the ST elevation. It's just kind of a mirror image, right? It's as if you flipped everything around. So the T waves are just getting dragged along. Yeah. So what could cause sinus tachy? Exercise, excellent. Pain. Caffeine. So infection, so you'd see this a lot in A&E. Sepsis, trauma, anemia. All right, good. Thyrotoxicosis. Great. All right. Is this regular?
Yeah.
Very good. And what's the rhythm here? So we said it's regular, so what's the rhythm? not really sure. I mean, I think I can see a PQRS, PQRS, but it's not the standard like what we saw here. It's not like this. It's not PQRS, PQRS. It's not clear cut. Yeah. So whenever you see a tachycardia, okay, with not a clear QRS, I'm not sure about the rhythm. The rate is 150 because there's like two big squares between each QRS. Yeah. So one of the rules is if you ever see an ECG with a rhythm with a rate around 150, 140, 160, yeah, always think atrial flutter, even if you can't see clear flutter width. I mean, now that we've said it, you could see the seesaw pattern. Yeah? But if you ever see an ECG with a rate around 140, 150, 160, always think flutter. So this is one of the things that need to just pop in your minds. Okay, so this is one of the tips and tricks. If you see an ECG at 140, 150, if it's bang on 150, usually I would say it's flutter. Okay. Right. So is this regular? No. What's the rhythm? Rhythm, not the rate. So we said if it's irregular, it's going to usually be AF. Yeah. So again, just like when you say it's regular, 70% of the time it's going to be sinus. If you have an irregular rhythm, it's usually going to be atrial fibrillation.
So when you say regular, what are you defining?
Irregular?
When you say regular or irregular, what are you defining?
So as I mentioned last time, you can say regular by eyeballing it and saying, yeah, this looks regular. So for example here, this looks regular. Yeah, if you look at it, you could just say, I'm going to pick one, see how many QRSs are between the QRS, how many big squares are between the QRSs, and I can count 2 squares, 2 squares, 2 squares, 2 squares, so this means it's regular. If it's too difficult, then you can use the pen and paper method, which again we discussed last time.
Yeah. I guess my question is that not a rhythm?
So, not always, because as again we saw last time, you could have a regular VT. So VT will be regular, a pace rhythm will be regular. Atrial fibrillation will be irregular. Variable heart block will be irregular. Multiple ventricular ectopics will be irregular. So they're different. So what you need to ask yourself when you look at an ECG is this regular or not? And then if you say it's regular, then you open up the chapter of regular rhythms, which could be sinus, which could be atrial flutter, which could be 2-to-1 heart block, which could be many things. Okay? Which could be sinus bradycardia. So there's lots of things that are regular, there's lots of things that are irregular, but the big category is regular or not. Okay? And you can say it's regular by eyeballing it and saying, yeah, that looks regular, or if it's difficult, then you could do the pen and paper method. And this will tell you if this is regular or not. Okay? Good. So, is this regular? You said no, it's not. What's the rhythm? Yeah, say yeah. And what's the rate? Drop the pen, that's a pen. And then we can count, yeah, and it's going to be around 160 beats a minute.
Can you explain the pen again, please?
Yeah, sure. So basically what we said last time is that every 5 big squares will give you 1 second. So if you count 65 big squares, you get the rhythm in 6 seconds. Okay? And then this multiplied by 10 is going to give you a rhythm the rate in 1 minute, basically. So you could so basically what you need is 6 times 5 big squares, which is 30 big squares. Okay, you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and so on, and then someone pulls you away, and then you look up, and then where was I, and then you start counting again, right? Or one of the tricks that I picked up is that if you usually drop a pen, it lands on 30 squares. I don't know how it does it, but it does it. So you just drop a pen, and usually it lands 30 squares. And then if you make life easier, and then you start counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Usually it will give you the rhythm that you're looking for. Okay? Can I just have a minute, because I think some of the slides have not saved properly, so just give me 1 second. Is that okay?